I'd like to thank Professor Azad for giving this opportunity to participate in this IC. I have no financial interest in this. A good ROP screening program is a collaborative effort between the ophthalmologist and the neonatologist. These are the two pillars of a successful ROP screening program. A good ROP screening program helps to identify the babies at risk, ensures timely detection, prompt treatment referral, avoids unfavorable outcome without burdening the available resources. So first question which comes to mind when you start ROP screening is whom to screen. These are the international screening guidelines for ROP, which suggest that babies less than 1500 gram birth weight or less than 32 week gestation age should be screened for ROP. However, the important thing to note here is higher has a star, which means unstable babies considered high risk to develop ROP by the neonatologist can also be brought into the screening program, which means if a baby is greater than 1500 grams birth weight, greater than 32 weeks, but the child is very sick and has high risk to develop ROP, he can also be brought into the ROP screening program. The Indian ROP group suggests that you can screen as high as 34 weeks with a similar higher criteria. So when to screen these babies? Once you've identified these babies have to be screened in the nursery, when should you screen them? The international guidelines suggest that you should screen them at 31 weeks post-conceptional age or 4 weeks after birth, whichever is later. However, the Indian ROP group suggests you can screen them at 31 weeks or 3 to 4 weeks after birth, whichever is earlier. Note the change. You can screen as early as 2 to 3 weeks in very low birth weight babies or very low gestational age babies as well. If this all sounds very confusing, it's easier to remember that you can follow the 30-day rule, wherein one screening can be done by 30 days. So all children who come into the screening criteria, by 30 days they should have at least one screening, and you can go as early as 2 to 3 weeks in very low birth weight or very high risk babies. There's no need to examine the children in the first 2 weeks of life. This chart will help you explain the basis of some of these guidelines. ROP screening is usually done. 3 important areas are there. 30 to 34 weeks where ROP usually tends to develop, reaches threshold ROP around 37 weeks, and then regresses around 40 to 42 weeks. So nowadays a lot of calls being made. Larger babies are developing ROP. A lot of reports are coming in from different parts of the country and in the developing world level. They say larger babies have to be screened for ROP. Professor Azad conducted this study wherein they said that we tested criteria where higher levels of gestation and birth weight were put, and we tried to screen over 650 babies which were born over the period of 2 years, and we studied that whether would it be prevent further blindness if we screened higher babies. So the important criteria which I highlighted earlier was the star. That is known as a third criteria, which if you bring in babies in a screening program which are greater than 1500 grams, greater than 32 weeks, but are sick and the neonatologist believes that they are highly suitable for ROP, you can bring these babies into the ROP screening program, and all these babies will be brought even without raising the guidelines. So this is just some gross result of the study, where they said that it would save 18 more eyes. Out of a total of 1300 eyes, if you over a period of 3 years, if you raise these guidelines. So we believe that the American ROP screening guidelines, which is 32 weeks, 1300 grams, are appropriate in our countries as well, if we continue to follow the third criteria, which is the neonatologist, if he believes the child is highly suitable for ROP, he brings these children also into the ROP screening program. Where to screen? The best place to screen is the neonatal ICU, where you can coordinate all the ROP activities and monitor the systemic status of babies. Combine them with routine neonatal visits. So it's a very ideal place where you can conduct these ROP screening programs. Very safe. What do you need? You need an intraocular scope, a condensing lens. 28 diopter is preferable because it will give you a larger field. Pediatric speculum is needed. A pediatric depressor is needed. You need dilating eye drops, a combination of tropicamide, phenylephrine, proparacaine topical anesthetic eye drops, artificial tears, a good ROP reporting form. How do you screen these babies? First and foremost, since medical legal error, it's very important that the parents should be informed what is happening to their children's eye. You have to explain the parents in detail. Informed consent is essential. Also, it's very important because the baby might be in your nursery and you are screening this child. You don't inform the child. It's all clearly mentioned on the discharge slip, but this baby might not know. The parents might not know that this baby was under an ROP screening program and fails to follow up after the baby is discharged. So it's very essential to discuss that these babies are at risk of developing ROP, and they need to continue with the ROP screening program even after discharge from the nursery. Sometimes written on the discharge slip and the parents don't know. So it's very important to explain them. Sometimes the parents say that ROP screening was not done for our child, especially if the child lands up with advanced stages of ROP, while the discharge slip it's clearly written. So it has to be discussed with the parents very clearly that your child is part of our ROP screening program and he should continue to be part of the ROP screening program till he is declared clear even after discharge. Ensure the baby is warm, dry, fed. Sterile instruments have to be used. All aseptic precautions have to be followed. It's typically how an ROP screening tray looks like. You have an indirect here, you have a bowl of Savlon, a saline, a lens, some swabs are there. The topical anesthetic drop is there. Pupillary dilation is essential. You can't dilate these babies with the commercially available drops or combination of phenylephrine tropicamide. It's usually if you have 5% phenylephrine drops or 10% phenylephrine drops, like comes in the form of Drosin, then you have to dilute 5% drops by 2 times, and 1% tropicamide commercial preparation you have to dilute by again 2 times. So you'll get a combination like this. If you have a pharmacy in your place, you can prepare this concentration there also. You can't use commercially available preparations because the dose will be higher, and so you just need to dilate them 2 times, 15 minutes intervals, 30 minutes before the procedure. Proparacaine eye drops is essential for topical anesthesia. First, you need to examine the anterior segment and look for corneal clarity. Tunic vasculosa lentis is a normal vascular finding on the pupil if you examine a child small enough. At 28 weeks, 26 weeks, 30 weeks you examine, tunic vasculosa lentis will be a normal finding. So don't be confused that what is there present. It's a normal finding. It tends to gradually disappear as the child ages. Pupillary dilation is a very important criteria because a non-dilating pupil is an indicator of plus disease and could harbor a very severe disease behind, so you need to look behind more carefully, look for lens clarity, media clarity. This is very important. If the pupil is not dilating, you have to be suspicious that it is plus disease. But what is essential is you have to see that the pupil has been dilated properly. Has the effort been made to dilate the pupil properly? Don't call the children after 1 week. If the pupil is not dilating, I will see after 1 week. If the child is having poor pupil dilation, harboring an aggressive posterior ROP behind, nothing will be left after 1 week to treat. So it's very essential to sit back, wait for 1 hour more, ensure the pupils are properly dilated, give a full trial of pupillary dilation again, and if still the pupil is not dilating, then you need to again go back and look behind and see the posterior pole and look for plus disease. So high degree of suspicion is needed. You just don't send these babies to come after next week or 2 weeks and see in the next cleaning cycle, because the ROP, a severe ROP might be present behind, and it might be missed, and it might progress over the period of next week and might become untreatable. So you have to wait and identify plus disease and properly dilate these babies and then proceed further. So once you've identified the zone, which sir has already told you, you identify the stages, whether it's immature, stage 1 to 5. Examination is usually done from nasal to temporal periphery, because nasally the retina tends to mature earlier, followed by the temporal periphery. So you have to examine all cores of the retina. A 20 diopter lens for beginners is a good idea, assisted by the ISO ROP. For beginners, if you place a 20 diopter lens at the nasal edge of the optic disc, at the temporal edge, if you see any ROP, that means you're dealing with the case of zone 1. This is just for beginners so that you don't confuse where the zone 1 is. Otherwise, zone is very easy to identify and seen posteriorly. A good ROP screening form is very essential because it helps to record data, it helps for you to follow up, it helps for you to refer cases, and if some other person is following up your ROP clinic every time, it helps you to assess, identify and avoid inter-observer variation. It's also important for medical legal purposes that you have properly screened and treated and referred the child in time. Sclera indentation is a very important component of ROP because these children are not anesthetized, just topical anesthesia is there. The child tends to move his eye. So sclera depressor like this is there, which is useful to stabilize the eye, rotate the eye to see the periphery, indent the periphery and see areas of interest, and contrast structures which you would not be able to see otherwise. However, you have to be gentle, otherwise you'll end with coronal haze, coronal conjunctival hemorrhages, etc. Remember, ROP is a very screening is a very stressful procedure, so it's best done in the nursery, best done in the presence of a pediatrician. It is associated with increase in heart rate, decrease in heart rate, change in respiratory rate, apneic episodes can occur. So you have to be aware that the problems can occur, and you have to be screened under proper control and monitoring by a neonatologist. If you're dealing with a type 1 ROP, then you have to treat and refer these cases, which we'll discuss in subsequent lectures. Type 2 ROP you have to follow up. You can stop the screening when the retina is mature, which is defined as vascularization till 1 disc diameter of temporal ora serrata, or till complete regression, around 4 to 44 weeks. So common question is asked, can pediatricians screen for ROP? Pediatricians can screen as far as the posterior pole is concerned. They can look for direct salvoscopic changes, but it's not a substitute for a proper ROP screening program. Is there an easy way to screen ROP? The RETCAM is an important tool which has gained widespread publicity for screening. It's a retinal camera. It's a wide field pediatric retinal imaging system, which all these photos you see are from the RETCAM only. It examines the anterior and posterior segment, allows fast documentation, This is how the RedCam, earlier model of the RedCam 120 looked like. Basically, it consists of a monitor, a handheld camera is there which you place over the eye. This is the next model of the RedCam which had come, and this is the latest model of the RedCam 3. It's an expensive instrument but is useful for ROP screening. This is the second generation ROP lens which is used, and it provides a field of 130 degrees, useful for examination. Again, the similar steps are done, pupillary dilation is done, and examining all the periphery. It's a mobile self-contained system for examination in the nursery, ICU, operating room, usually used by technicians and nurses, and avoids the stress and expertise of indirect thornoscopy. Useful teaching tool for parents and useful telemedicine purposes. A lot of telemedicine programs are running across the world, like where remote screening facilities, RedCams can be installed in different parts of the country, and they can screen and refer to experts, and experts don't need to travel, and children can be screened for ROP. Dr. Anand is here. iPhone clients are there, where telemedicine applications can be done and run through mobile devices. And it can also allows you to perform fluorescent angiography, which will help you identify clearly areas, clearly understand vascularization. However, it is not necessarily required in all eyes. It's just another capability which the RedCam allows you to do. And like in this eye, if you see, that it's not very easy to identify the ridge and all, and beginners might be confused what it is. If you see a fluorescent angiography, you can identify, that there are a lot of skip areas, and these areas are there, and actually the ridge is coming much behind. And this whole area needs to be treated. So this is the latest model of the RedCam shuttle. It's a maneuverable, transportable, lightweight device, and is useful for telemedicine. So basically, I would like to conclude by saying that ROP screening is a very essential component of the ROP program, and the ophthalmologists and neurologists both have to join hands and create accessible ROP screening and reduce childhood blindness due to this disease. Thank you.